Well, hello everybody, this is Chris back again with the Ancient Scholar, and this is video 3 and a several-part series on liberation from mechanical ventilation. So I'll just pick up where I left off on the spontaneous breathing trial, just talking about, look, I need to consider adjusting how I sedate these patients, because if I have somebody who's sedated to the point of being unable to interact with the ventilator, then clearly a spontaneous breathing trial isn't going to work. So yes, we sedate when appropriate, but we need to recognize that sedation is often like a dog chasing its tail, and it can get out of hand really quickly, and sometimes we need to break that cycle by decreasing sedation, letting our patient wake up, and seeing how the patient does. If the patient does very poorly for whatever reason, we can always then reinstitute sedation. And the same thing with analgesia. You know, we never want our patients in excruciating pain. But sometimes we need to look at perhaps modifying what we do a little bit so we can get a better idea of how our patient's doing, because we don't want our patients intubated either. We'd rather have our patients extubated, protecting their own airways, breathing on their own, and getting out of the hospital sooner ultimately. Okay, so that's a spontaneous breathing trial. You wake them up, let them breathe spontaneously. I prefer to keep them on the ventilator as opposed to a T-piece. Simply because a ventilator has apnea parameters and alarms, and I would like to take advantage of those settings as somewhat of a backup. But the evidence doesn't really say that keeping a patient on, say, CPAP and a ventilator is any more or less effective than putting somebody on a T-piece. But I think from a manpower standpoint and from a logistics standpoint, the T-piece trials are probably, at least in my bias, are probably going to be a little more logistically and labor intensive than simply putting somebody into, say, CPAP on the ventilator and doing the trial that way. And then, of course, we have the benefit of directly monitoring the volumes that the patient's pulling. Some ventilators, like the PB840, will actually calculate things like the RSBI and so on. So you'll put the patient in spontaneous breathing trial anywhere from 30 to 120 minutes, and you'll just see how they do. Maybe you get a blood gas. You're definitely going to monitor all the things that we talked about earlier. You're going to monitor their negative inspiratory pressure. You're going to monitor the tidal volumes that they're doing. You know, are they pulling at least 5 milliliters per kilogram? You know, can they cooperate and give you some vital capacity breaths, and are those breaths at least 15 milliliters per kilogram, or 3 times the tidal volume, or at least 1 liter in the adult? And how is their RSBI? Again, rapid shallow breathing index is not something that we measure on a patient that's receiving mandatory breaths. That's silly, because RSBI is a measure of how well the patient's doing, not the ventilator. So the RSBI is only measured during a spontaneous breath. So we would definitely assess. What I like to do is I'll assess the RSBI when I begin the spontaneous breathing trial. If I get the chance, I'll assess one somewhere in the middle, and definitely assess one at the end. So definitely at the beginning and at the end of the trial, and then I compare. And if that RSBI increased dramatically, and certainly if it's above 105, then that is a potential indicator that a patient's probably not going to do very well with weaning. Okay, so spontaneous breathing trial. Some other things we want to look at: how their respiratory rate, their heart rate, and their hemodynamics. Clearly, if they desat and their blood pressure crashes and their heart rate goes up to 130, greater than, I think, 20% the baseline, clearly these are some problems, and we may not want to extubate the patient at this time. Okay, so when we talk about doing a breathing trial, a spontaneous breathing trial, how can we accomplish that? Well, we can accomplish it through CPAP, through pressure support, T-piece. So let's talk about pressure support. You guys should be pretty familiar with what it is. Clearly it's something you use with SIMV. We know that it's basically a preloaded breath that helps overcome some of the airway resistance in the circuit and so on. But can we not use pressure support all by itself without mandatory breaths? Absolutely we can. And then what it does is it simply supports the patient with a preloaded pressure when they inspire. And so pressure support, let's be very clear here, pressure support only works during inspiration. It's a positive pressure delivered to the patient during inspiration. It can prevent activation, overuse of accessory muscles. Some people will actually start high level, maybe tendon pressure support, and then wean the pressure support down to, say, 3, 4, 5, and see how the patient does. But really, when we look at pressure support as a standalone mode of ventilation, once the patient is capable of maintaining whatever target ventilatory pattern, gas exchange pattern, minute ventilations, and so on and so forth, we would consider that optimal pressure support, and we generally want it modest levels of pressure support. If somebody is taking, say, 12 of pressure support to maintain saturation and good ventilation, we may want to reconsider extubating them at that point in time. Okay, another mode that we can wean in is CPAP, and CPAP is a little different from pressure support in that CPAP is a constant pressure. So I have pressure and flow during both inhalation and expiration, and we can actually do some interesting things. We can do CPAP with pressure support. So CPAP basically becomes PEEP, which it is analogous to PEEP, and then pressure support becomes a pressure delivered during inspiration above the PEEP or CPAP. Lots of different ways of skinning a cat, and I don't know that the literature is really concise about which way is the best. CPAP, pressure support with CPAP, bilevel, a lot of different things we can do. They all generally are equivalent, and even T-piece, taking somebody off a ventilator, putting them on a T-piece and supporting them is an effective way of doing a spontaneous breathing trial. Now, when we talk about actually weaning or liberating, there's another thing that a lot of people like to do, and that is what they'll do is, let's say my patient's in assist control, what they'll do is they'll put them into SIMV, and they'll give them, let's say, 10 breaths a minute with SIMV, mandatory breaths. And then they'll give pressure support with SIMV to support their spontaneous breaths. And then what they'll do is they'll gradually decrease the mandatory breaths. So let's say they're at 12, and then a few hours later they went down to 10, and the next day they're down to 8, and then the following day they're down to 6, and they gradually allow the patient to take more and more breaths and allow the patient to do more and more of the patient's own work with SIMV. Now, intuitively, this makes a lot of sense to me. Intuitively, I like the idea of using SIMV in this way, and SIMV was originally designed as a weaning mode of ventilation. However, when we look at the literature, it does appear that SIMV has the worst weaning outcomes in certain trials. There are, however, several trials that show little to no difference between SIMV, weaning somebody gradually with SIMV, or simply doing a spontaneous breathing trial every day and assessing and seeing how the patient does. Be that as it may, some providers don't recommend SIMV. They don't like to use it to wean. Some providers do. There's generally a lot of discussion there. In my anecdotal experience, it's just anecdotal, I've worked with a lot of physicians in this area that are very aggressive about weaning, and they'll have a patient in assist control where every single breath is essentially controlled, and they'll wake the patient up and go from assist control directly into CPAP. 30 minutes later, if the patient's doing well, they'll extubate them just like that, versus doing the SIMV slide for a couple of days. And as generally, again, this is all anecdotal, but generally patients seem to do okay. So I am more than happy to liberate patients aggressively in that way, and perhaps we should consider liberating some patients very aggressively if they do well. If they do very well on their spontaneous breathing trial, is there any need to then go from spontaneous back into SIMV and wean them down in SIMV, or perhaps simply extubate them? These are questions that you're going to come up against in the clinical environment, guys. Okay, we'll really quickly talk about protocols. A lot of facilities actually have therapist-driven protocols where the physicians all say, yep, you follow this protocol, and this does seem to be very effective. In fact, it seems to be more effective to allow people to run off of protocols and wean patients off of protocols than waiting for a physician to round once a day and the physician to write orders and then for the therapist to follow those orders. It seems that a protocol is very streamlined. Patients generally tend to do very well with protocols, and we can get patients extubated. Okay, guys, we'll just talk about failure to extubate in the next video.